I want you to imagine a world where you take just one shot every 6 months and you never, ever have to worry about swallowing your daily blood pressure pill again.
Which, I mean, that sounds completely like science fiction, right?
It totally does, like something out of a, futuristic medical drama or something. But it is happening right now.
It really is.
Yeah.
We're looking at a fundamental shift in how we approach one of the most common and, frankly, most stubborn medical conditions on the planet.
Yeah, and that is exactly our mission for today's deep dive.
Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May. We are unpacking a brand new 2026 article hot off the presses from the authoritative medical journal, The Lancet.
Right, the one led by Professor Michael Azizi.
Exactly. And it explores some truly revolutionary new drug therapies for hypertension.
Absolutely, because the reality of hypertension treatment has been stuck in a bit of a rut for decades.
Oh, for sure.
I mean, we've relied on the exact same basic mechanisms since the late 20th century. But this paper signals that the dam is finally breaking, and the way we manage cardiovascular health is about to be completely rewritten.
Okay, let's unpack this, because to really appreciate where we're going, we have to look at the massive contradiction sitting right in front of us.
The pill problem.
Right. We have incredibly cheap, highly effective blood pressure pills right now. You can get single pill combinations for like literal pennies a day.
Yeah, they're practically giving them away.
And yet, arterial hypertension still affects roughly 25 to 30% of adults worldwide. Global blood pressure control rates are just unacceptably low.
It's still the leading contributor to cardiovascular mortality.
Right. So why are we failing so badly when the tools are so incredibly cheap and accessible?
Well, it is the great paradox of modern cardiology.
Yeah.
You have this massive global population, hundreds of millions of people, and we ostensibly have the chemical keys to fix their problem.
But
the real world is infinitely messier than a clinical trial. We're dealing with therapeutic inertia.
which is basically what doctors just not stepping up the treatment.
Exactly. It's a fancy way of saying doctors often fail to increase dosages or change medications when a patient's blood pressure remains high.
Right.
Plus, we're facing rising global obesity rates, an aging population, and people living with multiple overlapping diseases.
It's a perfect storm.
It really is. But above all else, the single biggest hurdle is low treatment adherence. I mean, people simply stop taking their pills.
Okay, I have to play devil's advocate for a second here.
Go for it.
If adherence is the main issue, are we just creating these wildly expensive, high-tech scientific solutions for what is essentially a behavioral problem?
How do you mean?
Well, it feels like we have a leaky roof, right? And we've given everyone these perfectly good, cheap plastic buckets to catch the water.
Right, the daily pills.
Yeah, but eventually people just get exhausted from emptying those buckets every single day, so they just stop. So do we really need to invent a billion-dollar genetic umbrella just because people won't empty their buckets?
Okay, if we connect this to the bigger picture, it becomes clear that it is absolutely not just a problem of human behavior.
It's not.
No, not at all.
Yeah.
Yes, emptying the bucket every day is annoying. And taking daily pills can cause frustrating side effects.
Oh, yeah, fatigue, brain fog.
Right, constant trips to the bathroom if you're on a diuretic.
Yeah.
It is a daily psychological reminder that you are sick. But the pathophysiology of hypertension, the actual physical mechanism of the disease, is incredibly complex and multifactorial.
Meaning there isn't just one type of leak causing the problem.
Precisely. For a significant portion of patients, especially those with resistant hypertension or underlying chronic kidney disease or diabetes, the cheap buckets are completely missing the leaks.
Oh, wow. Okay.
Yeah, their hypertension isn't just a simple plumbing issue. It's a deeply ingrained metabolic and hormonal malfunction.
So the standard drugs just bounce right off.
Exactly. The old classes of drugs simply failed to address all the physiological mechanisms at play. The body actually actively fights back against the drugs we give it.
Okay, that is a very fair point. We aren't just treating forgetful patients, we're treating a remarkably stubborn disease.
Right.
Which brings us to the first major breakthrough in the Lancet paper. If the cheap buckets aren't catching all the leaks and people hate emptying them anyway, what is the alternative?
This is where it gets good.
Yeah, because I was reading this part of the paper about a drug called Zilebesiran, and I have to admit it completely threw me for a loop.
I'm not surprised.
It's a blood pressure drug, but it's an injection that goes straight to the liver. Why on earth are we targeting the liver for a cardiovascular issue?
So to understand that, we have to look at the body's main pressure control system, called the renin-angiotensin-aldosterone system.
Okay.
Think of it as a cascade of dominoes. The very first domino in that chain is a protein called angiotensinogen, and it is manufactured almost exclusively in the liver.
So the liver is literally the factory printing the blueprints for high blood pressure.
Exactly. For decades, our traditional blood pressure pills like ACE inhibitors or ARBs, they've worked by letting the liver produce that protein, letting the dominoes fall, and then desperately trying to catch them at the bottom.
Because they're just playing defense.
Right. They act as temporary roadblocks, blocking the receptors in the blood vessels so the pressure-raising hormones can't attach. But they wash out of your system in 24 hours.
Right, which is why if you miss a dose, your blood pressure spikes back up immediately.
Exactly. But Zilebesiran uses something called small interfering RNA, or SIRANE.
Which sounds so futuristic.
It is. We are crossing from traditional pharmacology into the realm of genetic modulation. Instead of building a temporary roadblock in the blood vessels, this SIRANE travels to the liver.
And what does it do when it gets there?
It intercepts the genetic messenger that tells the liver to make angiotensinogen, and it just destroys it. It essentially unplugs the machinery on the factory floor.
Man, to bring this back to our plumbing analogy, traditional blood pressure drugs are like running around a massive house, frantically trying to plug individual leaky faucets with your fingers.
Yes.
But Zilebesiran is like calmly walking down into the basement and just turning off the main water valve. You shut the whole cascade down at the source.
That's a great way to put it.
And the clinical trial results here are just wild. In the phase 2 Cardio 1 and Cardio 2 trials, a single subcutaneous injection, just a tiny shot under the skin, dropped 24-hour ambulatory systolic blood pressure by about 15 millimeters of mercury.
Which is massive.
Right. And that effect lasted for a staggering 6 months.
It is a remarkable achievement. By suppressing that liver production by over 90%, you get this incredibly smooth, sustained blood pressure reduction across the entire day and night cycle.
Wow.
And physiologically, the brilliance of this mechanism is that it prevents the body's natural escape response.
Wait, what does that mean, the escape response?
Well, with traditional pills, the body senses the drop in blood pressure and panics.
Yeah.
It thinks you're bleeding out or dehydrated.
Oh, so it tries to save you.
Exactly. So the kidneys churn out more of an enzyme called renin to fight the medication, trying to force the blood pressure back up.
But with the shot.
With Zilebesiran, because it has completely depleted the angiotensinogen, the raw material, the body's counterattack has absolutely no ammunition. The kidneys pump out renin, but the renin has nothing to act on.
It is beautifully devious. It completely outsmarts the body's defense mechanisms.
It really does.
But, you know, if you're listening to this on a jog right now, you might be thinking, wait, my body needs to raise my blood pressure when I exercise. So if I shut off the main valve for 6 months, am I going to pass out during a 5K?
It's a great question. For normal daily fluctuations like exercise, the body has secondary localized systems, like your sympathetic nervous system, that can still acutely manage blood flow and heart rate.
Okay, good.
Yeah, you won't pass out on a treadmill.
Yeah.
But your concern touches on a very real, massive clinical dilemma for emergencies.
Right. What happens if a patient on this 6-month injection is in a severe car crash and goes into hypovolemic shock?
That's the nightmare scenario.
Because for those listening, hypovolemic shock is when you lose a massive amount of blood and your blood pressure drops so low it becomes deadly. Usually your body's renin-angiotensin system kicks into absolute overdrive to clamp down your blood vessels and keep you alive.
Exactly.
But if we've turned that system off, we've removed their physiological safety net.
That is the crucial safety dilemma here. With a daily pill, if you get sick or have surgery, you just stop taking the pill and it's out of your system.
Right, in a day or so.
Yeah. But with Zilebesiran, you have months of permanent suppression. In an emergency room setting, if a patient on this therapy presents with shock, standard intravenous fluids might not be enough to save them.
So what do doctors do?
Emergency doctors would have to use intravenous angiotensin II, or heavy-duty vasopressors, to manually override the system.
Is there no antidote? Like, can't we just give them a reversal shot?
Well, there is research into a reversal injection, basically an antidote SIRANE, that blocks the blocker. But right now it takes up to 48 hours to fully restore the system.
Oh, wow, 48 hours. That is way too slow for an acute emergency like a trauma.
Way too slow. So this therapy will require a completely new set of clinical responsibilities. Medical alert bracelets, strict pregnancy counseling.
Oh, pregnancy, right.
Yeah, because a developing fetus absolutely requires this hormone cascade to form properly.
So it's a massive leap forward, but it demands immense respect.
Very well said.
Okay, so we've explored shutting off the main water valve in the basement, but what if the pressure in the pipes is still dangerously high?
Then we have a different problem.
Right, because that implies there's a completely separate pump driving the water that ignores that main cascade entirely.
And that brings us to the second major revelation in the Lancet paper, aldosterone. This is a massive hidden epidemic in hypertension.
Yeah, the paper points out that millions of people have unrecognized aldosterone dysregulation.
Exactly.
Their bodies are just pumping out excessive amounts of this hormone. And aldosterone is brutal. It essentially tells the kidneys to aggressively hoard salt.
And wherever salt goes, water follows.
Exactly. So the bloodstream fills up with excess fluid, driving the blood pressure through the roof, regardless of what other medications you give them.
Historically, we've tried to handle this by blocking the receptors that aldosterone binds to, using older drugs like spironolactone.
Right, I've heard of that.
But they come with a host of incredibly frustrating side effects. And more importantly, they don't stop the adrenal glands from producing the hormone in the first place. The holy grail has always been to stop the synthesis at the source.
But to stop that synthesis, you have to target a specific enzyme called CYP along B2. And this is where I find biology both fascinating and, frankly, infuriating.
Oh, the twin problem.
Yes,
Yep.
because that enzyme has a genetic twin called CYP11B1, which is responsible for synthesizing cortisol.
Right.
And cortisol is our critical stress hormone. We literally cannot survive without it. It regulates metabolism, reduces inflammation, manages stress. So basically, the body designed the essential keep me alive hormone and the destroy my blood pressure hormone to look like 93% identical twins.
Great design. Evolution.
Right.
It is a pharmacological nightmare. And that question, how do we block the bad twin without accidentally shutting down our ability to handle stress, is exactly why this new drug class took decades to develop.
I can imagine.
Yeah, the first generation of these drugs, called aldosterone synthase inhibitors, or ASIs, failed miserably. They weren't selective enough.
They hit the cortisol twin.
Exactly. They accidentally hit the cortisol twin and caused adrenal insufficiency, which is life-threatening.
But the Lancet paper highlights the second generation ASIs. Drugs like baxdrostat and lorundrostat. And these act like incredibly precise snipers, right?
Exactly. Baxdrostat is 100 times more selective for the aldosterone enzyme. Lorundrostat is an astonishing 374 times more selective.
Wow.
Yeah, they completely bypass the cortisol danger. It is a triumph of modern drug design.
Which is incredible. We are threading a microscopic genetic needle here. And in the phase 2 and phase 3 trials, like the BaxHTN trial, these drugs caused clinically massive drops in blood pressure for patients who were previously totally resistant to treatment.
They're life-changing.
But, and here's the thing, reading through the data, I noticed a pretty terrifying catch.
The potassium.
Yes. By entirely shutting down aldosterone, you don't just stop the body from hoarding salt, you also stop the kidneys from excreting potassium.
That is the sobering clinical reality. Aldosterone's job is to trade potassium for sodium. When you halt that process, the potassium has nowhere to go, so it builds up in the blood.
And that leads to hyperkalemia. And high potassium isn't just, a minor inconvenience like a headache. Potassium dictates the electrical gradients of your cells. If it gets too high, it can cause sudden fatal heart arrhythmias.
It's really dangerous.
Yeah, in one of the baxdrostat trials, specifically looking at patients with chronic kidney disease, the rate of hyperkalemia was around 41% compared to just 5% on the placebo.
Wow.
So we've solved the genetic twin problem, but we've created a highly dangerous mineral management problem.
Which means if these highly selective snipers hit the broader market, they will require rigorous, frequent blood monitoring, especially in the first few weeks of treatment. You can't just hand a patient a bottle of baxdrostat and say, see you in a year.
Right. Okay, so we've tackled the master switch in the liver with the RNA injections. We've tackled the rogue salt-hoarding hormone with the selective enzyme snipers. But there's a third element to this disease.
The actual blood vessels themselves.
Exactly, the pipes. What happens when the vessels physically squeeze shut and just refuse to let go?
That brings us to the endothelin system. Endothelin 1 is one of the most potent vasoconstrictors the human body can produce.
It just clamps down.
Yeah, it forcefully clamps down on the smooth muscle lining our blood vessels.
It's like a microscopic boa constrictor, wrapping around every single blood vessel in your body, aggressively squeezing them shut.
That's a vivid image.
And the drug stepping into the ring here is aprocitentan. It's a dual endothelin receptor antagonist. It basically forces that boa constrictor to uncoil.
Right.
In the precision trial, they looked at patients whose blood pressure was completely out of control despite taking 3 different medications at maximum doses. And aprocitentan still managed to significantly lower their blood pressure.
It's an incredibly powerful mechanism of action because it directly targets the vasculature, the actual pipes. It can override a lot of the other malfunctioning hormonal systems upstream.
But when you suddenly uncoil that snake and open the pipes, you change the fluid dynamics in the body very rapidly.
Yeah.
The pressure drops, but the fluid has to go somewhere, and it starts seeping out of the vessels into the surrounding tissue. The major side effect of aprocitentan is severe fluid retention. We fix the blood pressure, but now the water pools at the patient's feet and lungs as edema.
And what's fascinating here is how modern cardiology is adapting to solve these overlapping side effects.
How so?
Well, you have the endothelin blockers causing massive fluid retention, and you have the aldosterone blockers causing deadly potassium spikes. The paper outlines how the medical community is shifting away from trying to find one perfect magic bullet and moving toward an ecosystem approach.
Ecosystem approach. I like that.
Right. And a major part of that ecosystem is the natriuretic peptide system.
I love this part. This is the body's natural defense mechanism, right?
Yes. Atrial natriuretic peptide, or ANP, and beta natriuretic peptide, BNP. Your heart actually releases these proteins when it senses there's too much pressure and the heart muscle is stretching.
So the heart has its own internal sensor.
Exactly. They are natural diuretics. And vasodilators, they tell the kidneys to flush out water and they relax the blood vessels.
But there's a catch, I assume.
Always. For years, we couldn't use them effectively as a treatment because the body produces an enzyme that destroys these good peptides almost immediately after they're released.
But now we have drugs like sacubitril/valsartan, which work by inhibiting the enzyme that destroys the good peptides.
Precisely.
So instead of just blocking a bad pathway, we are putting a protective shield around the body's natural defense mechanism so it can do its job longer.
Exactly. And the Lancet paper points out that the future of hypertension treatment is combining these heavily targeted drugs with newer classes of medications, specifically SGLT2 inhibitors.
Wait, SGLT2 inhibitors? I thought those were strictly diabetes medications.
They were.
So how do they help with blood pressure side effects?
It's a brilliant physiological hack. SGLT2 inhibitors were designed for diabetes because they hijack the kidney's sugar filtration system. They force the kidneys to dump excess glucose into the urine.
Okay, that makes sense for diabetes.
Right. But here is the magic of osmosis. Water naturally follows the glucose out of the body. Furthermore, by altering the fluid dynamics in the kidney, SGLT2 inhibitors also help the body naturally excrete potassium.
Oh, wow. I see exactly where this is going.
Do you?
Yeah. If you prescribe an aldosterone sniper to lower the blood pressure, you risk a dangerous potassium spike. But if you pair it with an SGLT2 inhibitor, the SGLT2 drug naturally cleans up the potassium mess.
Exactly. Or if you use an endothelin blocker that causes fluid pooling, the SGLT2 inhibitor acts as a powerful diuretic, dragging that excess water right out of the body.
That is genius.
You balance out the fluid retention and the potassium spike simultaneously. You're orchestrating a harmonious physiological ecosystem.
So what does this all mean for us? We started this deep dive talking about a guy with a cheap plastic bucket catching drips from a leaky roof, frustrated that he has to empty it every single day.
Right.
What the 2026 Lancet paper is showing us is that the future of treating cardiovascular disease is completely abandoning the bucket.
Throw the bucket away.
Exactly. We are no longer just saying, take this generic pill to artificially mask the pressure. We are entering an era of targeted physiological hacking. We are looking at twice-a-year genetic shots that rewrite liver production.
It's incredible.
We are looking at highly selective enzyme snipers that can differentiate between nearly identical genetic twins. We are forcefully uncoiling the boa constrictors around our blood vessels and using diabetes drugs to perfectly balance out the side effects.
And if you or a loved one are among the hundreds of millions of people globally who are struggling with uncontrolled blood pressure, this research represents a fundamental shift in the standard of care.
It really does.
This isn't just about tweaking a number on a blood pressure cuff to make your doctor happy. It is about fundamentally reducing the residual hidden burden of heart failure, stroke, and chronic kidney disease that relentlessly persists even when the old drugs seem to be working.
We are finally getting to the root of the leaks.
We are.
It is incredibly hopeful, but it also completely changes what it means to be a patient in the modern medical system.
It does. And I think it leaves us with a rather profound question to consider.
What's that?
Well, if we can now safely and semi-permanently alter our body's fundamental blood pressure baseline with a twice-yearly genetic injection, what other daily routine maintenance functions of the human body will we soon outsource to semi-annual genetic tune-ups?
Oh, wow.
Will daily medication of any kind eventually become a thing of the past?
That is a wild thought to leave on. Imagine just going in for your biannual human oil change and being set for the year.
Sounds pretty good to me.
Thank you for joining us. Please subscribe and share the channel, What the Study Says.